Welcome back. I'm going to continue our discussion today talking about chronic graft versus host disease, which is a complication for our allogeneic transplant patients who had donor cells or donor transplant. So chronic GVHD is somewhat different yet alike with acute GVHD. It affects many more systems in the body. The way that we treat it is slightly different and the length of treatment is different. It typically takes 3 to 5 years after diagnosis of treatment to achieve control of GVHD. And in contrast with acute GVHD, we treat very rapidly with high doses of prednisone and then withdraw it, and that's done. About half of all post-transplant patients will develop some kind of GVHD in some system that requires a form of treatment. And nearly all of those cases will be diagnosed within the first year post-transplant. About 90% of all cases are identified then. 5 to 10% will be identified in the next 2 to 3 years post-transplant, although that's much rarer. We often use multiple different treatments or modalities for treating chronic GVHD, trying to find just the right fit of medication for the type or system of GVHD that the patient has. So everybody has their own personal set of risk factors for developing chronic GVHD. You don't have any control over these or changing them, but it's important to be aware of them because it impacts how our team and your home physician decide to treat the GVHD, how aggressively and how quickly we may treat it. So the older you are at the time of transplant gives you an increased risk. If you're male and you had a female donor, that adds a bit to the risk factor. If you had prior acute GVHD, that's an increased risk, although it's not directly associated by system. So if you had gut GVHD, it doesn't necessarily mean you will go on to have chronic gut GVHD, but we just know that there's an association between those two. The source of your transplant cells is also considered a risk. The lowest risk is from umbilical cord blood transplants, as those cells are the most naive. The next, bone marrow, is a little bit higher risk, and the highest risk is actually from peripheral blood stem cells, which is the most common type of transplant we do here, but we have to balance a lot of other factors and risk factors from those other types. And then who the cells came from. If it was an unrelated or a mismatched donor, you have a higher risk for developing chronic GVHD. Many more systems are involved with chronic as opposed to acute. We can see with acute GVHD, we're looking for skin, liver, and gut changes. With chronic GVHD, we can see mouth, skin, liver, GI, eye, genitalia, joint fascia, and lung changes. These are divided kind of between early and later occurrences. The earlier systems and signs that we see when we first diagnose are typically mouth, skin, liver, and gut, with the frequency there you'll see on the table. With skin GVHD, it starts as a rash, usually starting on the chest or the trunk. It's usually reddened areas. Sometimes it's painful or itchy, but sometimes it's not. We can usually diagnose this simply by photos and an assessment without having to do a skin biopsy unless we're trying to rule out other things. The best thing you can do to help prevent this, again, is sun exposure and protecting yourself when you're outside. Photos play a large role in diagnosing GVHD for us here in long-term follow-up. If you or your physician can send us photos of your skin or the skin rash, our attending physicians can often make a diagnosis and provide treatment recommendations to you in the comfort of your own home without ever having to come here to Seattle for that diagnosis. We have instructions on our website on how to take the best photos of your skin or for your provider to do so, so that we can make the best diagnosis and assessment from afar. Oral GVHD is another one of the first signs that you may see as you're tapering your immunosuppressant post-transplant. And this goes beyond just a dry dry mouth or taste changes, to begin to include sensitivities, especially to things like spicy foods, soda or carbonated beverages, or minty toothpaste, those kind of things. You'll notice that these things that didn't bother you in the past may start to become more sensitive or even painful in your mouth. There may be some sores, lesions, or tightness upon opening. So again, this is a system that photos are extremely helpful for us. They may show these white lacy changes called lichenoid changes that are very characteristic for GVHD. If we see these changes in oral photos, we definitely know that we're looking at graft versus host disease as opposed to something else. So again, because not a lot of people have an intuitive skill of being able to take photos of their mouth, we have documentation on our website, and we're happy to send to you as well on how to take good photos of your mouth, and even an instructive video, because it can help us so much in the diagnosis and treatment. Liver GVHD is also one of the first things that shows up on your lab tests. And as you're tapering your immunosuppression, you wouldn't notice any symptoms yourself, but your physician would note that your liver function tests may be abnormal, and would contact us for support. We do see changes in lung function as from GVHD. This is usually a later effect, but it can occur in the first year post-transplant as well. And unfortunately, this is one of those systems where the changes are not reversible. So unlike with a skin rash, we can treat it, it'll go away, and it's like it was never there. With lung GVHD, the changes cannot be reversed, so the best that we can hope for is to stall the progression and to prevent it from getting any worse. So for this reason, if you're diagnosed with GVHD in any body system, we will recommend having pulmonary function tests done every 3 months. And this is to help us identify any lung function changes before you even notice the symptoms and before it's affecting your function. IGVHD can occur as a later effect as well. This is beyond just the dry eye that you may be suffering post-transplant. This goes into dry, gritty, painful. Patients say it feels like there may be sand caught in their eyes, or any wind or air going across your eye could feel like scratching or painful. It's a dysfunction of the tear ducts. So initially your eyes may be watering more than usual, or you may be waking up with kind of some gunky stuff in your eyes, but eventually you'll find them drier and drier and needing more and more eye moisturizing and drops. The eyes as a system do not respond well to systemic immunosuppression or prednisone therapy, so we refer to an ophthalmologist or optometrist for their dry eye treatments such as drops, gels, special moisture lenses, many adjunct treatments that can be helpful for our patients. It's more rare, but we do see joint fascia involvement with chronic GVHD. This can stem from, we may see reduction in range of motion from either tightening of the skin or thickening of the skin around the joints, or from muscle or joint pain. It's typically bilateral, and this is one of the reasons why we do these range of motion photos. So if you've had them already, or you may be scheduled to have your range of motion photos in long-term follow-up, we take a picture of you in these kind of funny poses, but they're useful to show us what your baseline range of motion is when you leave your active team here. So if you identify any changes going forward, we can have you or your providers recreate these poses, and we'll compare them to the photos we have on file and see if there's been a change since you left transplant. GI GVHD is somewhat similar in presentation with acute. It involves either upper or lower GI. If it's upper, you may experience nausea, feeling full after just a few bites, some may possibly trouble swallowing or feeling increased tightness, or feel like pills or food getting stuck in your esophagus while you're swallowing. Or lower GI would be cramping, pain, or diarrhea after eating. Any kind of unintended weight loss is often a red flag to us that there may be GVHD involvement in your GI system. Typically, we would diagnose this based either on your symptoms, and often have to do an EGD or endoscopy to diagnose it. We do see genitalia involvement with GVHD. The numbers we're not as certain of the frequency because of either decreased reporting from patients or providers aren't aware that the genitals can be involved with GVHD, or what to look for and how to do the assessment. So with our female patients, it can often mimic hormonal symptoms or menopausal symptoms such as vulvar vaginal dryness, pain during intercourse, decreased libido, but it can progress to such an extreme that there may be a stenosis or narrowing or complete closure of the vaginal vault. So it's very important to identify whether this is GVHD or hormonal or aging changes. With our male patients, it's often skin changes, a whitening or tightening, sclerosis of the genital skin. So we actually have gynecologists here at the SCCA who specialize in GVHD in the assessment and treatment. If you're not able to come see those, they're always happy to consult with your local providers or gynecologist or urologist for the assessment and treatment as well. So like I said in the previous talk, even though these are a lot of new risk factors and concerns that you need to be aware of, there's still a lot that you can do to mitigate your risk and to keep yourself healthy and to help your providers with early diagnosis and treatment. Number one, avoid sun exposure to prevent GVHD flare. Be aware of any changes and report them to your physician or your provider or to LTFU. Just keeping careful track. If you notice any skin changes or rashes, take a photo, make a note of what medications you were on, where you were in your taper schedule when that initially showed up. That will help us a lot when determining is this GVHD and how should we treat it and with what medications. Keeping yourself healthy as much as possible. Any kind of infection or illness can often be a trigger to GVHD, as those immune system cells may go into overdrive to fight that infection, and then once that's resolved, they don't ramp back down and they go after some other system in the form of GVHD. So while you can't always prevent becoming ill or having an infection, just being aware that that could be a trigger, so that helps us put together the picture of whether we're looking at treating GVHD or something else. So how do we treat it? Well, the best thing that we have that we usually use initially is prednisone. And we use it slightly differently than within acute GVHD. But we'll typically start with moderate to severe GVHD, dose for at least a couple weeks to help minimize symptoms, prevent tissue damage, and then do a slow taper in order to minimize the side effects from prednisone, which include high blood sugar, osteoporosis, bone loss, or acute vascular necrosis. While we're tapering the prednisone, we try to ensure that there's another steroid-sparing agent or immunosuppression on board, whether it's your cyclosporin, tacrolimus, sirolimus, what you may have been on through transplant or may have already tapered off. Sometimes we have to change these medications in case one is better for a different organ system than another. We continue to monitor the drug levels of these drugs, similarly to when you were in the acute phase after transplant, but not as intensely. So you will typically monitor drug levels on a weekly basis until they're stable, and then many patients just have them checked monthly as opposed to twice weekly and with frequent dose adjustments when we're actively monitoring post-transplant. We have other treatments such as ECP. It's an apheresis procedure that typically takes place 2 to 4 times a month. It takes many more months to see results, but it can be effective when as a second-line therapy if the drugs aren't as effective. And we always have clinical trials going on here at the SCCA that's worth looking into or discussing with your provider, either here or at home. They do require some travel to the SCCA, but sometimes it's on only a monthly or more limited basis, so that may be an option for you to look into as well. And we have many other treatments adjunct to using systemic therapies. So we don't always necessarily need to jump into prednisone or start high-dose immunosuppression. If it's just a skin rash on a smaller surface area of your body, we may be able to use topical steroids or creams. Oral GVHD responds very well to a steroid rinse, a dexamethasone rinse in your mouth. Like I mentioned, the eye treatments are often just topical as opposed to systemic. We often use these treatments in addition to or instead of systemic immunosuppression or prednisone. So the take-home message is that you don't have to be an expert on GVHD. You don't have to memorize all of the systems that could be involved or all of the signs or symptoms, but just being the best advocate for yourself, monitoring any changes and reporting them to your physician or to LTFU in order to stay on top of things ahead of time. Just know that we're always here wishing you the very best health. Be patient with yourself going forward one day at a time. Thank you.